Welcome, Tracy Johnson. Tracy is the Director of Health Systems Analytics, the Canadian Institute for Health Information. As Director of Health System Analytics, Tracy Johnson is responsible and accountable for providing the vision, strategic leadership, and client stakeholder relationships to develop analytical products that address priority health information needs and promote their use. Prior to joining CIHI in 2005, she worked in quality and risk and hospital management, and prior to that in acute care and rehabilitation as a physiotherapist. She holds a Master's of Business Administration from the School of Management at York University and a Bachelor of Science in Physiotherapy from University of Toronto. So welcome, Tracy Johnson.
Thank you very much, Melissa.
Can you with us? We see
Thank you
and we hear you.
Okay, perfect. So today I'm going to talk to you a little bit about CIHI and what we do. I'm also going to talk about our early MAID work and how it connects to end of life and palliative care analytics that my team is working on. I'll try and tie this information to the research agenda for suffering today and provide you with some information on data that may help all of you with your research agenda. Before I start, I'd like to acknowledge that where I work today is on the traditional territories of the Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, and the treaty lands and territories of the Mississaugas of the Credit, and recognize that this land is now the home of many diverse First Nations, Métis, and Inuit peoples. What is CIHI? So CIHI is an independent, not-for-profit organization that provides essential information on Canada's health systems. We were established over 25 years ago, and we work closely with federal, provincial, and territorial partners and stakeholders across Canada. We want to disseminate information that helps inform health policy, management, care, and research for all Canadians. We're led by a 16-member board of directors, and we have representation from across the country. We're funded jointly by Health Canada, as well as negotiated agreements with the provinces. We work with Health Canada and the provinces to align our activities with their priority areas. Again, as I said before, we like to provide the foundation for measuring performance and outcomes of health services. And we try and support Health Canada and the provinces and territories to develop evidence-based policies and programs. Our mandate really is to deliver comparable, actionable information and to accelerate improvements in healthcare, health system performance, and population health across the continuum of care. This is where we fit into the landscape of the other not-for-profit and federal organizations. So Statistics Canada does population census, vital statistics, and health status surveys. Public Health and Protection is the Public Health Agency of Canada's purview. And then specifically, we look at the healthcare piece on its own. So we house hospital and residential, we look at hospital and residential care, health workforce, health system performance. We have some data gaps, which some of which we work hard to try and fill, but we care, we have data gaps with respect to care by private providers, some allied health services, and of course, health is closely linked to social services. This is all to say that we have a partnership framework, and we work with a range of health organizations and partners across the country to provide data and information, as I indicated previously, and that does include researchers such as yourselves. We host about 28 data holdings, 10 billion records, and we have pan-Canadian coverage for a number of them. So the data sets that we hold can be listed by types of care. So we have hospital emergency care, mental health, home care, long-term care, rehab, pharmaceuticals, clinical organ transplantation, knee replacements, trauma. Patient-reported outcomes. So we have some patient-reported outcomes in relation to joint replacements, and we have patient-reported experience data from hospitals that we collect. We have data on health spending, and we also have data on health workforce. We collect data from many sources. We're able to do it because we're a prescribed entity under PHIPA in Ontario, as well as other federal legislation. This enables us to collect, use, and report on the data that we collect. And as you can see here, wide range of stakeholders who provide us with the data that we have. So some of the health workforce data comes from the regulatory authorities, and the hospital data comes directly from provinces. So next, I'd like to talk to you a little bit about the end-of-life care and its connection to MAID that my team have been doing, and others at CIHI. So, and a bit of this I'll connect to what is our data, what does all of this mean in practice? So we've got a lot of data sets. What it means in practice is that we can look at patient journeys across care, so we can connect and link those data sets. We have the breadth, often out of different data sets. We can pick different things that we're interested in. So we can find identifiers. We can look at equity issues in our DAD data because we can look at sex, we can look at age, we can look at income. In some of our other data, we can look at different scales, like the home care data and the long-term care data has different scales for cognitive scales, as well as cognitive and behavioral scales, as well as physical scales. So our data is often a combination of administrative and clinical data. We do not have clinical data to the level that registries have, or those of you who have access or collecting research data have access to. So we often have to rely on proxy measures in order to try and understand an issue. And particularly, as you speak about suffering and patient experience with respect to MAID today, we would have to, our data is probably helpful to you if you can understand, and we could pick out some of the proxy level, proxy measures that might be helpful in trying to get a handle on some of the picture that you're looking for. What do I mean by proxy measures? So in DAD and NACRS is our hospital and our emergency department data across the country. So we have full hospitalization data from across the country. The emergency department data is full data in Ontario, Alberta, and the Yukon. And we have quite a considerable amount in most other provinces, but it's not complete. So when you look at the hospitalization records, palliative care has a specific code, and with that code, we can look at in the records what a patient's main reason for visit was for palliative care. So, but it doesn't give any information about what care was provided. We can understand the disease that the patient came to the hospital for with respect to palliative care, and if they have any other chronic conditions, they are also noted and in care. Now, with respect to suffering, we have diagnostic codes that can give some information about things like depression or anxiety and pain, but it doesn't necessarily tell us if these conditions were treated. So was the pain managed? What was the severity or the frequency of it? We'll be able to tell whether or not that condition was the main reason for admission to hospital or not. We can see in our hospitalization data if someone accessed MAID in hospital, but as Jackie said, many people receive MAID care at home or in private hospices. The next example is just a little around our home care data. So the home care data, as I spoke about before, it has more information on mood, well-being, and things like pain control in that particular data set. When it comes to end-of-life care, this is the data that we are working with, or that's available and that my team are working with to try and look at palliative care in Canada. So we use the hospital data, we use the emergency room data, we have long-term care data complex continuing care data, home care data, drug programs, drug data, and physician billing data. So we can link all of these by patient's OHIP card. There's other ways to link it if you don't have that, but in this case, we have the OHIP numbers. They're scrambled and de-identified, but that's how we link these data sets. And where possible, so Ontario and Alberta have more extensive data, so we often, if we don't have data across all provinces, we often have to use those as examples. And we don't have a lot of evidence that, you know, if only 15% of people get palliative home care in Ontario and Alberta, that situation is too terribly different across some of the other provinces. That said, things like palliative care are programs that are distributed differently and delivered differently across all provinces. So understanding the context and the policy is important when you're looking at our data and using it. So this is just connecting CIHI's work to the MAID work that's happening. So we previously released a palliative care report in 2018, and it gave us a baseline measurement of the palliative care landscape in Canada. We also spotlighted innovations in palliative care, as well as information on gaps in care and in data availability. So as I said before, one of the key questions for that report was, how many people receive palliative care in Canada? And palliative home care in particular was of interest to us because Canadians have overwhelmingly stated that one of the places they would like to die is not in hospital. So with that initial report, we were able to see that about 1 in 6 or 15% of people who died in Ontario and Alberta in 2016-17 received publicly funded palliative home care. And this is important because if you receive publicly funded palliative home care, you are 2.5 times more likely to die at home than those who do not. What you can see in the data is opportunities for earlier integration and better transitions of care for palliative care clients. So 1 in 5 long-term care residents with no record of palliative care and long-term care died in acute hospital. And 2% of those who had palliative care while in long-term care died in hospital. So one of the quickest, cleanest ways to improve palliative care in Canada would be to look at what's happening in long-term care, which is place of residence for many people. 84% of hospitalizations for palliative care were unplanned. And those folks with unplanned admissions to hospital spend a lot of time waiting in an emergency department. 10% of those hospitalized for palliative care waited for discharge to a more appropriate setting, and more than half of those folks died before they were able to be transferred. The likelihood of receiving palliative care differs by disease and age group. So those with cancer are 3 times more likely to receive palliative care than people with other illnesses. When we look at sex and income, we don't see any differences, but we see that if you are a younger Canadian or you're in the middle group, 45 to 74, you're more likely to receive palliative care than adult seniors or younger adults. And there's differences across all disease groups for unmet needs. I'm not going to dwell on these slides, but the research, the work that we did in this area, the analytic work, showed some data limitations with respect to looking at palliative care. So whenever you use our data sets, you will recognize there are limitations to the interpretation and to what you can actually look at. And we also identified in this particular report opportunities for better data and better measurement. So how does this connect to MAID? So as Jackie stated in 2016, when the legislation was enacted, the conversation at the time was very much about one can't have MAID legislation without, it's not a substitute for a lack of access or poor palliative care. So tied to the legislation is a need to report on palliative care in Canada. So we will be repeating the report again in 2023. And when we look at, the actual MAID records we have from hospital, 69% of those who have MAID in hospital are designated as palliative at some point in their final hospital stay. But only 30% of those folks had palliative care as part of their treatment plan prior to their final hospitalization. So some more opportunities for improvement. This is just, as I stated, we'll be bringing out a shorter report with data tables and infographics as we did previously. CIHI was involved in this initial work back in 2016 when we helped to develop a MAID information framework. So this is just for collecting health system information, and it was to explore, it was to help put together, at the time we convened a meeting of MAID stakeholders to understand what their health system questions were and their shared priorities. So this framework is intended to give folks a way to think about data collection and to think about some of the topics of interest when you're looking at the MAID data. So it's on our website. We do encourage folks to take a look at it and some of the baseline work if you're interested in understanding how we came to report some of the things that we report and that Health Canada reports. Finally, I'll just close by quickly letting folks know how you can access data from CIHI for research. So it's as simple as going to the link that's on this particular slide, and you can request access to our data, as well as requesting it be linked with some of your research data. So this particular CIHI.ca is our website, and on this particular web page will give you all the information that you need to access our data. So more traditionally, what happens is you fill out a data inquiry form, and then a team at CIHI makes contact with you around your needs. There's more detailed documentation to fill out. And often what would happen is the data would be linked internally at CIHI and then sent back to you. We have a pilot happening at the moment, which is, and which will be expanding all the time, but it's a secure analytic environment. And this will give researchers access, controlled, secure remote access to customized record level data sets. So all of our record level data sets are de-identified, but linkable to a lot of research data. This is again just some of the features of security if you're interested. And